So we're back with my guest, Dr. Samira Farouk, who's an associate PD at Sinai, Mount Sinai School of Medicine, and she's a nephrologist. And we're going to talk about now managing an AKI in the ED. So just to put some context here, in general, this is going to be a patient we've seen, we've talked to, we've sent a whole battery of labs on, and let's say the labs come back significant for an AKI. Probably this patient, we're thinking to admit them. My questions for you are going to revolve around how can we think through this a little bit more deeply before we just hit the admit button and get this patient in? Is there anything else we should be thinking about? I know we can divide AKIs into sort of pre-renal, renal, and post-renal injuries. And is that still how we think about renal AKIs?
I think there are a lot of different ways to, tease it out, but I think that is a great approach for this setting.
So let's say we know there's these buckets, but we don't know which one the patient fits into. Where do we go from here?
Yeah. And I think even before we get there, something that, we see often as nephrologists that are consulting in this setting would be before you're even thinking about what should we do to figure out why, I think there's some things that you should not do and things that you should really think about to avoid making this problem worse before we have some more data. And so something that unfortunately we see oftentimes is that, the patient is complaining of pain. And then, we are looking in the medication list and they've been given a, significant dose of ketorolac. And so non-steroidal anti-inflammatory obviously can make acute kidney injury worse. And so I would really be mindful in the emergency department setting of what you are doing in that moment that could potentially making an ongoing active process a little bit worse.
Sure.
And I think along those lines, the second thing is I think sometimes we always think isotonic fluids are always a great idea. There are times where isotonic fluid can actually also make things worse. And so sometimes acute kidney injury can be accompanied by hyponatremia. And so without adequate data, if you're giving isotonic fluids, you may cause a significant shift in the sodium that is too quick that then, we have to reverse and, prevent CNS problems. And so I would, before we think about what is causing AKI, think about what can we do to, prevent this from getting worse.
Sure. With the caveat that sometimes, we don't know they have an AKI until hours later. So we may have done some interventions beforehand going down a different clinical pathway.
Absolutely. Definitely.
However, yeah, that makes sense. Let's avoid NSAIDs, avoid unnecessary fluids if they're, if we're just waiting around. That makes
or even any medications that need to be dosed for kidney function, which is a lot of them. And so, sometimes opiates that are given for pain, particularly morphine, is mainly cleared by the kidney. And so if you give that to somebody that has impaired kidney function, it may have a more exaggerated effect than you were intending on. Yeah. And so so that being said, what data can be gathered in this acute setting to try to help distinguish the acute kidney injury? And so the urinalysis we really think about as this, liquid biopsy, it really gives us a lot of information about what is happening at the level of the kidney. And so point of care urinalysis can provide some information to start. And if there is an AKI, I would also suggest sending what we call the formal urinalysis to the lab while we kind of work with what we have. And so what are we looking for? We're looking for evidence of intrinsic kidney injury. And so we're looking for white blood cells in the urine, red blood cells in the urine, as well as evidence of glomerular damage, which can manifest as proteinuria or albuminuria. And so the UA is pretty sensitive. So if the UA tells us it's negative, most of the time that's going to mean that there is probably no albuminuria. The one caveat to that is that if somebody has a monoclonal gammopathy like multiple myeloma and they're spilling immunoglobulins into the urine, causing light chain cast nephropathy, for example, that may not always be picked up on the UA. It's a lot more sensitive for albumin, but again, that's not really a acute ED problem.
Okay.
That is something
this
that
is a dumb question, but when I'm looking at a urinalysis, the one we've sent to the lab, it just says protein. And now that means it's just counting all the different proteins. We can't really distinguish between whether it's albumin or,
Correct. But it is more sensitive for albumin.
Okay. So the first thing you would do if you saw a patient with an AKI is avoid the things we talked about, send an official urinalysis and look for some sort of thing in the urinalysis, whether that be some whites, some red blood cells, or some protein.
The other number I really like from the urinalysis is actually the specific gravity. And we kind of call that, poor person's urinosmolality. And so that specific gravity is going to tell me a little bit about the kidney's concentrating ability. And if it is very concentrated, then that is going to maybe push me a little bit towards a pre-renal etiology. And so if we think about something like acute tubular necrosis, for example, depending on, how severe it is, sometimes the kidney will, what we call, lose its concentrating ability. So the urine becomes very dilute. And so what are the numbers that I'm talking about? So specific gravity, that's a normal, it's really impossible to give a normal range, but concentrated would be like 1.020, something in that range. And then very dilute would be something like 1.005. And
Okay.
so specific gravity of water is 1. And so the closer to 1 you are, the more dilute you are, and the higher you go, the more concentrated you are. And so if you're looking,
So it sounds like what you're saying is you look at the urinalysis. If you're seeing stuff in the urine that shouldn't be there, you're thinking this may be more of a intrarenal injury. And if you're seeing something that's highly concentrated, you're saying this may be more of a pre-renal injury.
so the kind of the classic story would be, say somebody is coming in, nausea, vomiting, diarrhea for the last several days. Now they have an acute kidney injury, no history of chronic kidney disease. What I would expect to see on the UA would be no cells, no protein, and a very concentrated urine. You give some fluid and that creatinine gets better.
Okay.
So that is a kind of the very, basic scenario. The caveat to that, and why this can sometimes be a little bit more challenging to interpret, is that somebody has CKD, they can of course have a pre-renal AKI on top of their CKD.
Sure.
And so in that setting, the urinalysis may not be
Kinda
as
confusing.
bland as we expect. But it's kind of put all the pieces together.
Right. Okay. All right. But yeah, I like laying out sort of some of these principles and the ways that you think about these things. So that's great news for me. So the urinalysis can tell you a lot. What else? We're
What
trying
else?
to into these 3 buckets.
Yeah, so for the pre-renal, bucket of things, volume assessment of course is very helpful. And so pre-renal, we're thinking about hypovolemia. We're also thinking about hypervolemic patients in the setting of, for example, cardiorenal syndrome. And so what's happening in that is that you have, poor cardiac function that's leading to what we call renal venous congestion, and that leads to this AKI that looks like could be hypovolemic, but is really kind of the opposite. And so the treatments, of course, are very different. If you have hypovolemic pre-renal injury, we're giving some isotonic fluids. If you have hypervolemic pre-renal injury, we're going to, of course, need to diurese. And so the challenge is that the urine studies can look identical, very concentrated urine. And then the other urine study that we can think about, which has some limitations, is the urine sodium or the fractional excretion of sodium. And so, we learn in medical school, less than 1% pre-renal, more than that, more than 2%. Think about intrinsic renal. Really, the setting that this is ideal in is in the patient that is oliguric and has not received any fluids. And so I'm not sure how many patients that we actually see fit into that category before this test is sent, but that is where it is most sensitive and most specific, is in that particular setting. So somebody walks through the door, they've been oliguric, they haven't gotten any fluids yet, and now they have a low urine sodium or a low fractional excretion of sodium. And so that is one other marker that can help you understand not necessarily volume status, but effective circulating volume, which is what we're really kind of talking about here.
So is one way to think about the fractional excretion of sodium to say, if this person is pre-renal, their kidneys are not seeing enough blood. Either
Exactly.
that's because they're volume down, they're septic, they're hypovolemic for gastroenteritis, or they have heart failure and they're not seeing enough blood because their heart's not working well enough, or they're so congested that the blood is not passing through. Would you put hepatorenal sort of in that same category as well?
Yes, absolutely.
Okay.
And so
Other problems in the body having a secondary effect on the kidney sort of sound like, to me, like pre-renal. And then when you check the urine sodium, since that kidney isn't seeing enough, it's taking sodium back, making the urine have a low amount of sodium in it because it's trying to concentrate the blood or retain fluid, I guess.
Right. So to, put that a little bit differently, what all the pre-renal etiologies have in common is low effective circulating volume. And one great indicator of that is a low urine sodium. Okay. And so why is the sodium low? The kidney is seeing, less intravascular volume. And so that makes the nephron what we call very sodium avid, because it is trying to reabsorb all the sodium to try to expand the intravascular volume. And so in a situation like cardiorenal syndrome, that's actually, you know, detrimental, but in a hypovolemic situation, of course, that is the, you know, the desired response. And so, yeah, it's either hypovolemia, hepatorenal syndrome, or cardiorenal syndrome would be the kind of three main categories for pre-renal.
Gotcha. Okay. And so the treatment for all of those, it sounds like, is to sort of fix the underlying problem.
Right.
Which as ED docs, you know, generally, I think as we're doing our workups, if we're clinically seeing some indication of hepatic failure or cardiac failure or hypovolemia, generally speaking, we're pretty good about sending those labs, making that diagnosis, and sort of reversing those underlying causes. So for me, that pre-renal thing, I feel more comfortable with that.
Yeah, and I think, you know, volume assessment is of course can be challenging, but, you know, using multiple parameters and putting them together. So one, just your physical exam. Is there evidence of edema? What do the mucous membranes look like? You know, skin turgor, things like that. Orthostatics, though, you know, have limitations as well, can be another data point. Point of care ultrasound to look at the IVC can be another marker. And so, but again, even using all of those, it can be very challenging sometimes to tell, is this more of a, you know, overloaded picture, or is this more of a hypovolemic picture?
Sure. And just to get back to staying on the pre-renal thing, you don't feel that a ratio of greater than 20:1 of BUN to creatinine is useful for pre-renal?
I wouldn't say it's not useful. It's just something in my clinical practice and many of my colleagues is not something that we really rely on. But again, that can be used as another data point if things are a bit unclear.
Okay. All right. So sometimes it'll work, sometimes it's not.
Yeah. And, you know, there are other things that can raise the BUN and not impact the
GI
creatinine.
bleeds and,
right.
Yeah. Okay.
Steroids. Yeah.
Okay. Okay. So let's leave pre-renal. Let's go to the other one that I think is more straightforward, which is a post-renal obstruction. If we're thinking about that, what is that patient going to look like, and what do we do about it?
Yeah, post-renal, easiest and fastest one to fix. And I think also very easy diagnostically. And so bladder ultrasound, a lot of urine that's there usually comes with a history of not necessarily anuria, but can just be decreased urine output, or sometimes the patient has not really noticed any change in their urine output. And so we're thinking about, you know, somebody that's older or somebody that has a history of obstruction in the past, has, you know, history of radiation. If someone has retroperitoneal fibrosis, that can impact the ureters and leads to some sort of more proximal obstruction. And so I think if it is available to you and convenient, a point of care ultrasound to assess the bladder. Is it distended? How much urine is in there? And then if possible, to look at the kidneys, look for evidence of hydronephrosis. That will give you the diagnosis. And if it is a bladder problem, Foley catheter will fix it. And if there are cases where you can have the bladder is okay, but the obstruction is more proximal, so you have hydronephrosis, but the bladder is actually, you know, decompressed, that's going to require, you know, more urgent urologic or interventional radiology intervention to decompress the GU system. And so what are things in the history that you might look for? Of course, you know, older, men with possibly a history of prostate hyperplasia that may or may not be known. What is the age we think about? You know, somewhere between 60, 65. Over that would be the kind of right demographic for that. You can see it in younger patients as well. May or may not be on something like a tamsulosin. And sometimes that's accompanied by other medications that may lead to, you know, the bladder not working normally. So somebody that's taking, you know, Benadryl every night to sleep, or they've maybe been prescribed a new medication that is affecting the bladder's neurogenic capacities.
What are some of those meds that tend to cause sort of urinary retention that could lead to sort of an obstructive picture? Benadryl.
So anything that's going to be, you know, kind of anti-muscarinic, antihistamine type things, those could do it. Anything that is, you know, used for neuropathies, in theory might be able to do it. I haven't really seen it, but, you know, gabapentin could potentially maybe contribute to that. And sometimes there are other things that, our urology colleagues would tell us can make the bladder not work normally. So constipation is actually a really important one that, when we work with our urology colleagues on the inpatient side, if, somebody had a Foley catheter, now we remove it to do a trial avoid, and the bladder is still not, waking up in a sense, they would, say, make sure that there is a good bowel regimen. And so there's a lot of things that can contribute to why the bladder is not appropriately, doing what it needs to do. But I think in this context, the key here is to not necessarily figure that out. But if you see a neurogenic bladder that is full of urine, to decompress that in as timely as a way as you can.
Or severe hydronephrosis or something, some sort of mass obstructing the ureter.
Right.
Okay.
And another pearl that we use to diagnose obstructive uropathy is severe hyperkalemia that is, quote, out of proportion to the rise in the creatinine. And so an example of that would be the creatinine is 2.5, but the potassium is 9. And the reason for that is that when there is obstruction, you can have something called a type 4 renal tubular acidosis, which is, leads to hyperkalemia. And so, if I get a call overnight about, kind of this scenario, obstruction goes very, very high to the top of my list. Of course, maybe the creatinine of 2.5 for that person is a really kind of severe AKI, but that's kind of a general pearl.
That's great. I love that. Yeah, I never knew that. Okay. So, and I think it's well within ED's scope of practice to throw an ultrasound on the kidneys and the bladder to make sure there's no hydro, no huge urinary retention in the bladder. So I think that's a totally easy and reasonable way to rule out an obstructive AKI. So, okay. So it sounds like, just to go back, pre-renal, we're talking about problems before the kidneys, liver problems, heart problems, volume problems. Post-renal, we're talking about things after the kidney. So that would be something clogging the ureter, a mass, a tumor, fibrosis, something making the bladder not unable to excrete urine. So that would be BPH, that could be constipation, or just medicines that are making that person have a hard time peeing. Am I missing anything in those two differentials there?
No, I think the other, pearl about post-renal injury is that the obstruction can be anywhere along the whole GU tract. So just because the bladder is not looking like it's about to explode does not mean that the person does not have an obstruction, because again, you can, and there are even cases where for example, some patients with retroperitoneal fibrosis, they may not even develop the classic hydronephrosis. And so at that point, obstruction is really kind of a clinical diagnosis where all the other pieces fit, but you don't see that classic dilatation that you might see because it might be a little bit earlier on. So again, if it's possible, and I don't know if this is what you all do, but taking a quick look to see if there is evidence of dilation of the kidney system, and if there is, that gives you the answer, and then also taking a quick look at the bladder.
Yeah, definitely. So you can throw a probe on the kidneys, throw a probe on the bladder, look for hydro, look for urinary retention. Okay, so that's great. So then that brings it to the part where I get the most confused, which is renal injury. And I know these patients are generally going to get admitted. They're going to get worked on by medicine. My question for you is, are there things we can do if we're suspecting that to sort of expedite a workup? Yeah, so in my mind, at least the way I've understood this, and I could be wrong, is that one would divide this into acute tubular necrosis, where there's something wrong with the tubules, acute interstitial nephritis, where there's something wrong with the tissue of the kidney itself, or sort of a glomerular disease where there's something wrong with the glomerular function. Is that sort of how you think through renal injury?
Yeah, I think anatomically, as you described, is the perfect way to approach it. So glomerulus, tubular, and interstitial compartment we kind of think of together. So ATN or AIN. You mentioned the glomerulus, of course. And then the other component that we sometimes might forget about is the vascular component. So that would be something like thrombotic microangiopathy. If you remember like TTP, HUS, those are more vascular kind of injuries.
Okay.
And so, yeah, so if we think somebody is having intrinsic injury, then the question is, which of those 4 compartments is being most affected, and the urine studies will give us some indication about that. And so, again, looking for the presence of red blood cells or white blood cells. And so if it is, again, they're not really rules, but if you have a very, kind of white cell heavy urine sediment that has pyuria, the patient's also presenting with dysuria, then we might be thinking about, pyelonephritis, urinary tract infection, which can cause AKI. There can also be, drug-related causes of acute interstitial nephritis. So the classic story there would be, somebody was just discharged, they had some sort of infection, they were started on an antibiotic, and now they're coming in with acute kidney injury. And so that could be potentially an AIN in that setting. And then ATN, acute tubular necrosis, is going to be what we see in patients most commonly with, severe sepsis, not always related to hypotension, can be, but also in sepsis, you have this kind of inflammatory milieu, and the chemokines, interleukins, those themselves can be toxic to the tubules and cause an ATN. And so we can see normotensive patients with sepsis that also develop acute tubular necrosis. And then the glomerular injury is the one that is probably going to require a little bit more investigation if we have suspicion for that. And so, this is when, again, a little bit maybe out of scope for the acute evaluation, but something that the nephrology team would think about and the medicine team would be, is this more likely a nephritic syndrome? Is this more likely a nephrotic syndrome? Things don't always present classically, but things that you could do potentially in the emergency department would be, if you note that there is proteinuria, you note that there is a new albumin that's potentially new, then I might start to think about nephrotic syndromes. Those are typically going to be associated with more edema or anasarca, edema everywhere, compared to the person that is, coming in with new, hypertension, there's hematuria and a little bit of proteinuria, and the albumin is maybe normal. That might be more of a nephritic syndrome. But the next step would be, again, I don't know if this is in the scope of your practice, would be to quantify the proteinuria. So a spot urine protein to creatinine ratio would be the kind of next step to try to diagnose the cause of glomerular disease.
Okay, so let's say we've diagnosed sort of an AKI, we think it's renal. We sent a urinalysis. We're going to admit the patient. What else can we do before we admit that patient?
I think that beyond, urine electrolytes, so urine sodium, you might send a urine urea, urine creatinine, and the quantification of the proteinuria, if you have picked up any, I think that would be adequate.
Okay.
And,
so can you talk about the quantification of protein? I don't think that's something we standardly, I don't tend to do that in ED. Not that I don't want to, I just don't know about it.
Yeah, I think, is it really going to add to the acute management? Probably no. But I think if you're asking me, what can you do to kind of help the inpatient team, have a step ahead, that would be the next step. And so what are we talking about? So we're talking, the question is, how much protein is somebody excreting in their urine over a 24-hour period? And so normally that should be very low, technically, less than, 200 milligrams over the course of 24 hours. And so 200 milligrams is 0.2 grams. So if somebody has glomerular injury, specifically a podocyte problem. So we think of the podocyte as being part of the filter. So the way that I explain it to patients is, glomerulus is like a coffee filter, protein are the coffee grounds. If your filter is injured, grounds are going to come into your coffee. And so the numbers that we're thinking about are, if you have anything more than, 200 milligrams, that would be indicative of some sort of damage to the filter. And so in the context of glomerular disease, when we think about nephrotic versus nephritic, one of the variables that we use is nephrotic range proteinuria. So that means more than 3 to 3.5 grams excreted over 24 hours.
Sure, but that requires a day of collecting urine.
Right. So one way that we kind of get around that is that we can do something called a spot urine protein to creatinine ratio that can also give us an estimate of that 24-hour excretion. And so what you need for that is, so you order it as a urine protein to creatinine ratio. So the lab will measure your spot urine protein in one sample, and then we kind of adjust that by dividing the urine creatinine. And so that kind of gives you this kind of makes up for the lack of 24-hour collection. And so that will give you an estimate. So the one caveat to that is that assumes that the creatinine is in what we call steady state. And so if you're seeing a patient with acute kidney injury whose creatinine is going up or going down, then you may over or underestimate. So in somebody that has a worsening acute kidney injury, their creatinine excretion in the urine goes down. And so that ratio will be falsely up. But again, it still gives us an estimate. So if somebody has, a spot UPCR of, 10 or 12, I'm not going to just discount that because they're in a, AKI, but I would say that, there's some proteinuria there. And the
Okay,
reverse
that
is
makes
also
sense.
true.
So basically you're looking for proteinuria, and in that setting, since you can't see over time, you're sort of seeing the ratio, how much protein is this person excreting versus a theoretically fixed baseline of creatinine that they should be excreting.
Right.
If that ratio is high, then that person may be having a nephrotic syndrome, I guess is what you're thinking. Right. Okay. All right.
Yeah. Could definitely be. So the spot urine to protein creatinine ratio, unlike the urinalysis, which is more specific for albumin, this one is going to get all the proteins. And so again, that's important in patients that have a history of monoclonal gammopathy, or maybe that is kind of why they've come in to begin with. That might end up being the new diagnosis.
Okay. So let's talk about urine lights. What are they for, and are they useful? Urine sodium we sort of touched on because we talked about a pre-renal. You would think that the urine sodium would be low because the kidneys are trying to reabsorb as much sodium as possible because they believe that there's a volume issue. So theoretically, in an intrarenal injury, the urine sodium would be high. Am I right about that?
Theoretically, yes, but we often see cases of, ATN where the urine sodium is less than 20 and then, undetectable. And so why is that? If there are nephrons that are, healthy and have not been as impacted, they may be able to do enough to, kind of get all the sodium out of the urine. So I think it can be hard to interpret these data in isolation. And so if I see urine sodium less than 20, but then I spin the urine and I'm seeing lots of dark granular muddy brown casts, I'm not going to say that this is not ATN just because the urine sodium is less than 20.
Sure.
And
but
not
is it
relevant.
Something you'd want to have as like a data point?
Yeah, definitely. I think it doesn't hurt to do that. Again, urine tests are cheap and non-invasive. And so on the inpatient side, we actually do a lot of serial urine testing. And sometimes with patients with ATN, the first urine sodium value may be less than 20. But if you keep checking it as the injury evolves, the urine sodium eventually may cross that into the over 20 threshold.
Okay. All right. So urine sodium, I understand sort of the point of doing that. What about these other electrolytes?
Other electrolytes, so in the context of acute kidney injury, probably not as helpful diagnostically. Urine potassium, it gives us a measure of how well the kidney is excreting potassium. And so, if somebody has AKI hyperkalemia and you think it's because of the AKI that they're hyperkalemic, urine potassium probably be low, but does that help you in that particular setting? Probably doesn't add that much. And the urine chloride can sometimes be helpful in helping us understand how well the kidney is acidifying the urine. And so the urine chloride becomes a little bit more helpful in, acid-base disorders. Maybe you remember when we think about non-anion gap metabolic acidosis, we talk about this urine anion gap or urine charge difference in which we need urine sodium, potassium, and chloride. And so, there's been some debate about, should all the urine electrolytes be ordered? Should it just be urine sodium or should it be all three of them? I don't think it really matters too much. But I think what's most important in the evaluation of AKI, if you're going to send them, is to make sure you get the sodium and urea with the creatinine, because without the urine creatinine, you can't do those calculations.
Okay. So talk about the urine urea and urine creatinine. What are those doing?
Yeah, so in somebody that is on loop diuretics or thiazide diuretic, that may increase their urine sodium. And so in that setting, the fractional excretion of sodium we can't really interpret that because you're altering what the nephron would do. And so you can use this other metric called the fractional excretion of urea, which is not impacted by that. So the cutoffs are a little bit different. So for FE urea, less than 35 is the more pre-renal variety, greater than 35 is the more intrinsic variety. But again, how much we're using those in practice is, plus or minus. I think it's just one other data point, but I think in the nephrology world, we would use other clinical parameters just as much.
Yeah. Okay.
I think one other thing I'll say about FE urea and the FE sodium is that if somebody has underlying chronic kidney disease, then that is going to kind of impact their kind of baseline ability to be sodium avid or to reabsorb urea.
So would you send that urea on all patients or just patients that are on diuretics where it's going to replace the sodium?
Yeah, I mean, I think starting with the sodium is a good start. Again, if we think about, the cost and what it's going to do, I think often they're just kind of sent together,
Okay.
just because so you have them
Just
both. But
yeah.
if you're really going to like pin me on that, I would say you could start with the sodium first. But
Okay. And you mentioned urine creatinine.
you would need to send the urine creatinine separately because part of the formula is to calculate fractional excretion of anything, not just sodium or urea, is to include the urine creatinine in the formula.
Oh, so you can't calculate a fractional excretion of sodium unless you have the urine creatinine as well.
Correct.
How about, I remember reading about urine eosinophils to diagnose acute interstitial nephritis. Is that real? Is that just medical school stuff or?
Yeah, that is probably medical school stuff. We don't use that. It's no better than really flipping a coin. And so urine eosinophils are not a test that we ever order.
Okay. Is there anything you do, or is that more just a clinical diagnosis for the nephritis? You're just trying to.
For acute interstitial nephritis, often can be a clinical diagnosis, being on a medication that, has this association, plus minus seeing white blood cells in the urine. I mean, again, if we really get into the weeds here, there are cases where you can actually see red blood cell casts in acute interstitial nephritis. So, but again, not really relevant for this discussion,
Right.
But the real way to diagnose any of these intrinsic etiologies is to do a kidney biopsy. And so that's going to be the definitive way. These other things are just to help us kind of figure out which one of these might be more or less likely.
Okay. And I've seen that a lot of patients that tend to get admitted tend to get renal ultrasounds when they come in. What are those looking for? And is that something, well, I guess, what are you looking for there?
Yeah, so I think there is a few different things that we're looking for. If you have somebody that's coming in with a pre-renal hypovolemic acute kidney injury or cardiorenal syndrome, and you did the intervention and things got better, I think there's really no need to get a kidney ultrasound. If the patient has is discharged and then has a new diagnosis of chronic kidney disease, I think that every person with CKD deserves one kidney ultrasound, in their life. But that is, again, an outpatient thing. So in the inpatient side, what are we looking for? So this is going to be AKI, where we thought it was something, we did an intervention, things didn't get better or are getting worse. We're doing the ultrasound to look for, is there evidence of obstruction that, has not been captured before? And I almost always will order the kidney ultrasound with a bladder with a post-void residual, because you might miss a subtle obstruction in somebody that, does not have the overt hydronephrosis, but is not emptying the bladder completely. So that's one thing to look at. The other thing to look for is kidney size. That can give you, that's another thing actually thinking about evidence of chronicity. And so kidneys normally around 10 centimeters or so. If they're very small, then that would be evidence of chronic injury. Or if there is a size mismatch, that might give you some evidence of something called transplant nephrolitis. So that kind of came naturally to me, but renal artery stenosis, which can also happen in the transplant. And so why is that relevant? That can be a cause of acute kidney injury, high blood pressures that are hard to control. So basically you have, impaired flow to one kidney. So that kidney becomes smaller and then the other one is the normal size. What else are we looking for? You might be looking for kidney stones that you can see on kidney ultrasound. Or, in theory, there may be a mass that's there. There may be cysts that you may find.
Okay.
So I think those would be some of the main things that you'd be looking for.
Okay. And a question I've had, and I think about this a lot, let's say patients in the ED ruled out obstructive causes, or at least looked for that, didn't see any overt evidence for that. Pre-renal, it's not that, it's AKI. Is it reasonable to, let's say we send off urine lights, is it reasonable to start a trial of fluids just to see, will that help? Or is that don't do that until you figure out something else first?
I think it's reasonable to, if there is any suspicion that this may be a volume related issue, as long as there's not a reason to not give fluid. So as long as they don't look like they have hypervolemia, as long as, if there is a significant hyponatremia, that probably should be looked at a little bit before you give an isotonic fluid, because the problem is that you can rapidly overcorrect. But yeah, I think it doesn't hurt to give a small fluid challenge to start.
Okay,
pending
great.
those other things.
All right. So just to sort of summarize, I don't have any more questions, but sounds like what we're saying is patient has an AKI, we've diagnosed that. First thing we should be thinking about, which I think we tend to be pretty good at, is ruling out those pre-renal causes, because we're always looking for heart failure, liver failure, gastroenteritis, sepsis, septic shock. So rule that out. Make sure we rule out obstructive causes by throwing a probe on the kidney and the bladders, making sure there's no retention, placing a Foley if there is. And then if the patient is intrarenal, we're going to admit that patient, but sounds like what we could do just to help out is send off an official urinalysis, send off urine lights and a urine protein to creatinine ratio. I mean, that pretty much gets things started, and maybe start a little trial of fluids and get the patient admitted.
Yeah, I think that would be a great plan. I think that one other thing I would say is if you do find evidence of obstruction on your point of care ultrasound, to order a formal one. Sometimes what happens is that there becomes this kind of chart myth that somebody saw something, but there's no real documentation of that. So if you can't save those images into the EMR in some way, to have a real ultrasound that is done. And even if you put the Foley in and decompress the system, that's fine. But it's always a good idea to take a look at the kidney as well to see if there's hydronephrosis and other things.
Great. Anything I missed?
No, I think that's great.
Awesome. Thank you so much.
Thanks for having me.